Good morning, everyone. Today's JC topic is T-scan occlusal analysis system. The masticatory system is a complex and consists of TMJ, masticatory muscle, ligaments, associated tissues, and dental occlusion. The dental occlusion is varied due to several factors, such as tooth alignment, dental arch size, tooth position, and tooth eruption sequence. Normal occlusion is the alternative treatment goal, encouraging contacts in all the teeth with the heavier ones in the posterior segment than compared with the anterior segment. These occlusal force can be located with many techniques by using a articulating pepper, an occlusal indicator wax, or a SIMSOC. The occlusal contacts can be located and can be recorded, and the occlusal force are indirectly implied. Some digital occlusal indicators, including nathometer, a dental scale system, and T-scan system, can be available. Among these, T-scan system can record temporal changes related to occlusion, that is, occlusal contact time sequences and the disocclusion time. The T-scan 3 system is the newest version of the analysis of both static and dynamic occlusion with great precision. Although some reports on the utilization of the T-scan system to assess subjects with normal occlusion and malocclusion are available, none of them have compared with the percentage of the occlusal force among the malocclusion types. So the T-scan consists of primarily three major components, which include sensor, handpiece, and software. Out of these three components, sensor is the major portion of the T-scan, which records the occlusal force. The sensor is connected to the handpiece, from which the T-scan is connected to the laptop. The handpiece has a USB port, which can be connected to the laptop, which has a software, which is called T-scan Nova system software. So now coming to the sensor, how does it works? The sensor works by means of resistive um, resistive capacitor. So whenever there is a current passes from the upper layer of the sensor to the lower layer of the sensor, this current passing is interrupted when the patient bite. So by means of measuring the amount of current interrupted, we can calculate the amount of force exerted. However, the sensor cannot calculate the how much absolute value of the force exerted on the sensor, but it can relatively calculate with compared to the other parts of the sensor. So the sensor can be reutilized by means of using EPA registered hospital disinfectant containing O-ophthalmide is recommended, such as CDEX OPA. This is the display which we can see consists of the T-scan software system screenshot. So here we can see this is a graph which talks about the biting cycle of one particular patient. So this is the by chewing cycle of one particular patient where the patient achieved maximum intercretion. So it has a 3 point A, B, C, D. So each cycle has a four components, which is A, B, C, D. So A1 means the first chewing cycle of the patient. So the patient start from the point A when the patient have a contact from with the upper and lower teeth. So when the patient reaches the maximum intercretion, the curve reaches the B1. From B1 to C1, the patient will be in the maximum intercussion. So when from the C1, the curve declines, which means the patient start to disocclude. So the disocclusion time can be calculated from minusing the time taken between the C1 and D1. Like which the other graph which can be seen here is a pictogram, which is used to locate the maximum force exerted on a particular arch when the patient bites in the maximum intercussion. Here you can see the pink spot is the maximum amount of force exerted when the patient bite, and the other side of the arch also can particular point can be seen with the pink spot which shows the highest biting force exerted on the arch. And there is one more important feature in the T-scan software system, which includes the trajectory of force. So this you can see a one one force component which is derived from one particular point and travel towards the other point during the biting cycle of one particular patient. So this trajectory of force shows the force which travels from where which direction to which direction. The T-scan system also have one of the other feature which is helpful for locating the particular point in a patient clinically. So this is called overlay method, which can use overlay of the 3D scan system into the T-scan. So we can incorporate the 3D scan system into the T-scan system, which will be helpful in finding a particular spot in the occlusal occlusal view of the patient arch. Now coming to the article occlusal force distribution in various angles mallocclusion and evolution by T-scan 3 system. It is published in Journal of International Dental and Medical Research in 2009, published by Titirat et al. The aim of this study was to compare and evaluate their occlusal force distribution in the maximal intercuspal position by using T-scan 3 system. Now coming to the materials and methods. This study was approved by Naresuan University Ethical Committee, Thailand. Around 100 subjects were participated in this study. All of them had symmetrical dental arch with a minimum of 28 permanent teeth, 17th in each quadrant. In addition, they showed no restorative material, dental implant, fixed prosthesis, past or undergoing orthodontic treatment, molar relationship of with classification on one side different from the other side are excluded from the study. Also the patient with the transverse or the vertical dimension monocosis are also excluded from the study. These 100 people are classified into three major classification, which is taken as an angles classification and divided into four groups. These groups are class 1 malocclusion, class 2 division 1, class 2 division 2, and class 3, which has 25 for each group. Collection of the data were separated into two phases. In the first visit, impression of the subject maxillary and mandibular dental arch were taken for diagnostic models. Mesodistal width of the maxillary teeth was measured by using a LCD digital caliper and then recorded into T-scan system. In the second visit of the patient, the subjects were seated upright in a dental chair with their Frankfurt horizontal plane parallel to the floor. Pre-recording by the T-scan, they were instructed to bite into the maximum intercuspation several times. They were asked to bite into T-scan sensor in the maximum intercuspation and hold for 3 to 5 seconds before releasing. The percentage of relative occlusal force distribution were recorded by selecting a maximum intercuspation mode in the program. Summation of the relative force at maximum intercuspation were recorded at three separated regions, that is molar, which include first and second molar, premolar, and the anterior. All recording procedure were repeated in 3 times and their mean values were recalculated. Now coming to the result, the sample consists of 100 people. The sample description and percentage of the relative occlusal force distribution among the malocclusion types are shown in the table. There were no significant difference in the subject's mean age. Significant difference were found among the mean of overbite. The highest value was observed in class 2 due to, where the lowest in the class 3. The significant difference were found among the means of overjet, except between the class 2 due to and the class 3. The highest value was observed in class 2 division 1, whereas the lowest in class 3. The means of occlusal force distribution anterior, premolar, and molar region are also shown in the table. At the anterior region, the highest value was detected in class 2 division 2, while the lowest in class 1 At the premolar region, the highest values was detected in the class 2, while the lowest in class 2 due to. At the molar region, the highest value was detected in class 1, while the lowest in class 3. With respect to the region, there were no significant difference in the mean force distribution among the molecules. This picture shows the amount of force distributed in each classification. So the first picture shows the amount of force distribution among the class 1, and second picture shows amount of force distribution in the class 2 div 1, and the picture C shows the amount of force distribution in the class 2 div 2. The picture D shows the amount of force distribution in the class 3 molecular. The result in this study from the utilization of the T-scan system clearly indicated some similar patterns of the subjects occlusal force distribution despite their different angles monocclusion which have never been reported elsewhere. With its reliable property of the digital measurement, T-scan system was developed for some analysis and evaluation of the occlusal contact distribution by measuring the occlusal distribution of the force, but not the absolute bite force. Its high reliability could be obtained when it is used to perform repeated measurement. Its sensitivity and the variability of the high definition sensor were affected by repeated closure over more than 20 times. To overcome some human error in this particular study, all subjects were instructed to occlude in the maximum intercuspation 3 times. A tendency of force distribution toward the posterior region was shown in this study, which can be observed in the molar region 61 to 67%, followed by the premolar 24 to 28%, and the anterior region 8 to 11%. This study also shows it in accordance with the Agbaje et al. And the Kadir et al. In each region, all malocclusion possesses a wide range of force. This may be contributed to difference in the patient arch shape and the tooth position on dental arch. Apart from the highest mean value of the overbite, the highest occlusal force at the anterior region was disclosed in class 2 div2 when compared to those in the other malocclusion type, which were not significantly different. Although no correlation between the overbite and ankles classification was seen in previous report, some relationship between the overbite and occlusal force at the anterior region was observable in the study. With respect to the bite force and occlusal contact areas, subjects with normal occlusion were disclosed with the highest value, followed with class 1, class 2 div 1, class 2 div 2, and class 3 monocclusion. By using a digital system, some similar occlusal force among the subjects with different angles molar relations were documented, but without data of the occlusal force in the each region. Now coming to the conclusion, in all malocclusion, the posterior region was the area with most force distribution. In each malocclusion type, there was significant difference in the force distribution among the molar, premolar, and anterior region. Relative occlusal force distribution in each region were not significantly different among the malocclusion. Now coming to the critical appraisal, the title is clear and informative. The type of study is not mentioned. Abstract is well structured. Text is well written. Ideas and materials are correctly attributed. Research design is cross-sectional study. Discussion and conclusion is clearly stated. There are adequate reference in Vancouver style.